Okay, so today is a very important day for us. Today, our guest on the channel, on the request of many members and audience on the ICU channel and ESBICM, today we have Dr. Harish Mallapura Maheshwarappa with us, and he is one of the renowned faculty in the critical care. Everybody knows him. But what we are going to have that today he himself will tell us so many queries, addressing so many queries of the viewers regarding critical care as a branch, and his advice and his words of wisdom he will share with us. So I'm very privileged and honored to welcome Dr. Harish. Sir, very welcome and heartily, bottom of the heart, we are very thankful that you have spared time for our ICU channel and beyond ESBICM. Welcome, sir. Namaste.
Thank you, Ankur.
Sir, your introduction is such that if I start jotting down your introduction, almost 10-15 minutes will pass away. So, in short, can you please give a formal introduction yourself to our audience who are listening?
Sure. Uh, as you are aware, myself, Dr. Harish Mallapura Maheshwarappa.
Mm,
Currently, I'm placed at Bangalore, working as Director, Institute of Critical Care Medicine, Kaveri Hospitals, Bangalore.
mm,
In terms of my journey, I just want to give a brief thing.
mm,
So, many of you guys aware regarding my qualifications and all. So, in terms of professional journey, so previously I was attached with Narayana Rudayalaya as head of the department critical care medicine. Before that, I served as head of the department in Yashoda Hospital, Hyderabad. So currently I'm in Bangalore. So I work as both an intensive care physician and infectious disease specialist. So
mm.
other than my critical care routine clinical work, so I am the current president, Indian Association of Respiratory Care, and editor-in-chief emeritus, Indian Journal of Respiratory Care. So it's a brief about myself, and we'll unwind as we go with a conversation down the line.
Thank you, sir. We'll come to that. But, sir, I just want to ask you, when you chose critical care, I think 10, 12 years back, as far as my information or I remember that you are one of the first DM critical care in the country. Am I correct, sir?
Yes, yes.
So at that time, sir, critical care was not a branch which many people would have chosen to. So first, I would like to ask you, what was there in your mind when you were considering critical care at that time? What made you think that I should be choosing this field of specialty? Was a mentor, or from the starting you were inclined towards it? What made you feel to choose this critical care as a branch, as a specialty of career?
So this point, I want to just elaborate in depth, Ankur, for our
Mm,
audience and all. See, like in India, so I'm also one of the candidate through the government medical college. I done my MBBS from Mysore Medical College from Karnataka through like state entrance.
mm,
After that, again, post internship prepared for entrance for All India. So during our period, like almost nearing to 25 years back when I joined MBBS, in Karnataka, we were hardly having only four government medical colleges. So when you done your MBBS from government college, so our mentality is like further speciality, that is post graduation, super speciality, all we wish to like continue in the government colleges only.
yes, yes, sir.
So then our options were either you fight for All India entrance or maybe AIMS, PGI or JIPMER entrance. So
Mm,
these were only the options. Then post internship from Mysore, I shifted to Bangalore. So like started coaching for post graduation entrance for All India and AIMS and all those things. So my dream branch was to do internal medicine. So like
okay.
other than that, I never thought, okay, I want to do any sort of the surgical branches and all. So then, given All India, like we were having very limited seats during that time. So then I got a rank in All India. Then comes like options, which college, which place, which course and all. So unfortunately, in government college through All India, so I was not able to get general medicine, internal medicine course. So then in Karnataka, we were having one system called ComEd-K. So that is for mainly private colleges. So I got
Okay.
a good rank where I was able to choose internal medicine or any other post-graduation branch. But so again, I told like, okay, we want to do in a government setup only. Then comes first round happened. So then I thought, okay, maybe next round I might get general medicine. So took like diploma in pediatrics in Calicut, Kerala.
Okay.
Um, uh, like we have to do formalities and was not supposed to start the clinical work and all. So just I joined and again appeared for the second round. So then there were options like TB chest, like MD in chest medicine, MS ophthalmology, MS general surgery, MS ENT, diploma in radiology, all sort of diplomas. But again, there was no option for going for the MD internal medicine. Then third round happened. So then before going to the third round, so then like lots of conversation happened. Okay, why can't you choose anesthesia? So anesthesia in and around they play a peri-operative, post-operative, intra-operative physician role. So then it's a end branch. Okay, no need to think of like further going for super specialty. You can settle in a place wherever you want, and
Mm.
it is an upcoming subspecialties are there like pain medicine, critical care medicine, cardiac anesthesia, pediatric, neuro anesthesia. So these kind of thought process, like while conversing with the seniors, came into my mind.
Okay.
But per se, as an subject, anesthesia, I was not aware at all. Means in our internship also, hardly we got 2 weeks of postings in anesthesia, but we were not able to get any idea, no exposure, what's going to happen in anesthesia. So in the final round of All India entrance counseling, so then I took MD in anesthesia in Nagpur, so Government Medical College, Nagpur, Maharashtra.
Okay.
So then I started my career in anesthesia. I was one of the frustrated like person. See, for me, doing a post graduation is okay. You wear the stat and go for the rounds, patient interaction, so interaction with the family. So you follow the patient till the recovery, till the discharge. You do the OPD. So that was the passion kind of this one. Okay. So then I was frustrated. Then I thought I will go for one more attempt of entrance. So from Nagpur, I traveled to Madhya Pradesh because I think Indore or Bhopal I traveled to give one more time All India entrance
Okay.
in my second year of MD anesthesia. Okay, but unfortunately, not able to get a good rank because I have to do
Okay.
more night shifts and all. So then I thought, okay, so somehow we'll finish MD anesthesia. So then there was some vague idea. Okay, there is something like okay, critical care medicine is there as specialty kind of this one. So then post MD, I finished my MD in 2011 June. So post MD, I came back to Karnataka. See, by that time I was already married. So in my second year MD only, I got married. So my wife was also doing MD anesthesia, fortunately or unfortunately, Karnataka, in a city in Davangere. So when I came back, so
Uh,
we started lots of dilemmas, what to do, kind of this one. Because so in Maharashtra, so mine was the first batch post MD, they introduced bond, like
yeah, 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 sir.
service bond. So then, okay, a dilemma was whether to go and finish the bond in one of the colleges in Maharashtra because post MD marks wise they had some sort of like allocation of where we need to serve the bond and all. But attempted the counseling for that also. I got in Nair Medical College to serve 1 year bond. So then, I kept my luggage in Nair hostel. Again, lots of thought process. Okay, if I go to do a bond, 1 year I am going to waste. Okay, so then I came back. No, what I'll do is I'll not go for doing the bond. 1 year I'll do something. So in terms of fellowship in critical care, I don't know what to do. Kind of this one. So then, I came back to my wife's hometown, that is Davangere. So then we met couple of clinicians in Davangere. Like one of the urologists, he suggested, okay, why can't you go to Bangalore? So post MD, they have certain options in Narayana Rudayala, like maybe a fellowship in cardiac anesthesia, critical care, like whatever you like. So you can go and explore some options, kind of this one. So then I came to Bangalore. Like this is almost in a 1 month gap. So July, so I came like July first week to Narayana. So then I enrolled myself for IDCCM. So that is where my critical care journey started.
Okay.
So I joined for the IDCCM. So then again, there was thought process. No, I'm like sticking 1 year in NH Narayana for IDCCM. Post that I need to go back to serve the bond. I'll do one thing. No, I'll like write a mail so that I want to surrender the IDCCM seat. So I'll go back to do the bond, kind of this one. Okay. So again, still there was no clarity what to do, but I want to do something kind of this one. Okay. Then see, for IDCCM during that time, so we need to pay 10,000 rupees to Indian Society of Critical Care Medicine.
Yes.
So that is as a like one of the fee, kind of this one. Okay. Then they returned the DD back, demand draft. So then I return a mail to them. So again, travel to Mumbai. So with a dilemma. So one day I visited the department in Nair Medical College anesthesia. Again, the same thought process. No, I can't do this anesthesia anymore. Then again, next 2 3 days only came back to Bangalore. One more mail I sent to ISCCM education department saying that there was some confusion happened. Please
Don't cancel.
reconsider my application for IDCCM. I want to continue. So with a kind heart, they like okay, told okay, you continue, kind of so. So there started the proper critical care training. So then I got interest day-to-day practice and all. So then I was exploring what I can do next. So then I came to know that there is something called European Diploma in Intensive Care Medicine. So my thought process was okay, maybe IDCCM with EDIC. So then they announced the like FNB applications and all. During that time, FNB was there. So in that period, it's almost, I'm telling, 15 years back. So there was an option like on an institution basis, you can do IDCCM and you can opt FNB in the same institute. Uh,
Okay.
like if they give a permission, kind of this one. There was no strict rules on that. So then we thought, okay, like they were in need of working ants and all, they given a permission. So then I appeared for FNB entrance. So I got rank around 27 All India. So then I took the same hospital in Bangalore, that is Narayana. So then I was doing both IDCCM and FNB. So when I was in last 2 months of my IDCCM, there was a big announcement of like first time MCI recognized DM critical care in India. So that is from Tata Memorial Hospital. Okay. So then I applied for that. So like when I was giving my exit exam of IDCCM, so almost 2 days prior, there was an entrance for Tata Memorial Hospital, that is DM in critical care medicine. It's a physical entrance. I traveled to Mumbai. So then given an entrance was a toughest entrance. So then I thought maybe there is no scope, kind of this one. I came back to Bangalore, given my IDCCM. So with curiosity, after 2 3 days, then I called the student section of Tata Memorial Hospital to find out my result. So because the flow of the entrance was you give entrance, so next day result will be there. Next to next day they will call for the interview. So top 10 rankers, kind of this one. Then I thought no announcement, maybe some
Nobody
problem.
called. Huh?
Nobody. So then they told we have some technical issue. What is your roll number and all? They announced you are in the first rank.
Ah, oh.
Yeah, okay. So everything, it's a fate basically. So then they asked, are see 10 o'clock I called them morning. They asked, are you able to come at 1 o'clock for the interview? Obviously, I am in Bangalore. To reach airport itself, I need 2 hours. So then I told no option at all. I called my mentor, Dr. Jiggy Divetia. So then I told, so is the head of the department of critical care medicine during that time, sir, this has happened. So what can I do? Then he told, so we are calling 10 members for interview. Hardly 3 4 are able to come. So you come tomorrow, no problem.
Okay.
Attended the interview. So then on the same table only I got, okay, I got selected. So good questions, good conversation. So that is how I enrolled for India's first MCI recognized DM in critical care medicine. So then that started with my story of critical care learning and all. It's like
Wow.
lots of ups and downs. It was definitely fate, I can tell.
Very inspiring, sir. I think those who are listening, they will get so much inspiration from this journey. Now, how does it feel after, I think 10 or 12, 14 years back later? How does it feel to be one of the first DM critical care of the country?
So definitely those dilemmas were worth. Okay, my decision was worth taking
Mm.
because that pride will be there for my life. So like first MCA recognized DM in critical care medicine. So that's definitely an honor for me, for my teachers, for my alma, my parents, for everyone. So that is going to carry forwarded. So whenever I think about it, okay, so the flow of the journey of enrolling for the DM and how I excelled throughout my 3 years of DM critical care medicine. So I feel very happy, very much fortunate to be the first DM in critical care medicine. No repent on that, definitely.
Sir, you made us all proud also. So you are a fantastic teacher also. We'll come back to that. But just a little question. At that time, when you choose this DM critical care, obviously devoting such amount after anesthesia, after IDCCM, FNB, lot of amount in the DM critical care. Critical care was not very much means enthusiastic people were there that about that time. So what was the myths regarding critical care in the people's mind even that time and today? Which is the most common myth people have, students have? Can you tell us?
Yeah, Ankur, basically, see, it's almost 15 years back to do a hardcore critical care course for 3 years and to sustain and survive during the residency. That was the question. And like even in my interview for enrolling for the DM, the question was, okay, 3 years you have DM curriculum. After that, you need to do 1 year of like service bond. Are you okay for it? That was one of the question which I asked in the interview also. Again, as a branch itself, like it was an evolving branch, even though we were having like IDCCM and FNB critical care and all, like whether we were able to sustain that work stress, balance our work life, and what lucrative job options we are going to have. There were
Yeah,
some uncertainties
very.
definitely were there during 15 years back. And majorly in India, there was no defined way of practicing intensive care medicine. Like, okay, you have a purely closed, open, semi-open, semi-closed. So nobody knows like how our some sort of like placement in terms of positioning in a particular corporate setup or maybe a government setup, how we are going to make lucrative ourselves, visibility ourselves. So lots of questions were there in my mind also. But later everything explored, everything opened up in a smooth way.
So, sir, so now you have been in critical care for almost 15 years, what I can calculate. So, typically, what is your day in the ICU? If you want to narrate it, a typical day in your ICU, can you give a slight brief about that? How does your day start and ends?
Usually, Ankur, see, our traveling time to the hospital, it varies somewhere between 40 minutes to 1 hour.
Hmm.
And what I do is like when I start maybe around 7:30 from my home, so
Hmm.
I give one call to the ICU resident or an ICU consultant on the floor who stayed for the night. Okay. So then briefly we'll take an overview. Like so any major event happened in the like night or maybe early morning, any specific tough patient got admitted on the floor or any logistic issues or whatever it may be, briefly, very quickly I'll get the highlight so that I made my mind okay where I need to concentrate immediately when I go on the floor, kind of this one. So that starts there only. Either it may be, as I told, patient care, or maybe some administrative issues, or maybe some logistic issues, or maybe handling a tough family, or like conversing and like some sort of breaking some sort of the bad news and all, whatever it may be. So I'll make a thorough mental setup while on the way to the hospital itself. Okay. So when I reach hospital, maybe around 8:30, 8:45. So then like I'll make a move to ICU. So we'll take a rounds first. So basically, like there also we'll have some idea. So where to start, kind of this one. So my clinical rounds is going to be very, very academic discussion with a plan, okay, uh, and with high evidence-based, experience-based discussion at the bedside. What is going to happen, like whether night managed by the residents or maybe a junior consultant or associate consultant or maybe a consultant, we have a very good like thorough discussion of the cases at the bedside, because I believe always then and there only you need to catch the points and recall, discuss and make your plan. It should have a backup of academics also. So that is what you
Very true.
remember for like long duration. So otherwise, see, if you just discuss only troubleshoot at the bedside without thinking about the rationality, without thinking about the theory backup or evidence for that particular case, so then you are going to lose many of the concepts and all. So most of my rounds are going to be very good thorough discussion and all. So then we'll make a plan for the day. So like with proper acute troubleshooting with in-depth discussion and all. So then by the time we finish the rounds, it's going to be 1.5 hour. So after that, so we go for a coffee. So maybe it's around 10:30, 10:30, something like that. Okay. Like 1 or 2 person will stay on the floor and remaining will go to have a coffee. So there we might meet maybe other specialty like colleagues, and we will not waste too much of time. Quickly, maybe 15-20 minutes, we'll finish coffee and we'll come back. So again, one more rounds. It is just to again make sure like things are like
In
happening.
place.
Yeah. So whatever we planned and it has been started kind of this one. Okay. So around 11:30, 12 o'clock, we'll start our counseling. So whenever I am on the floor, so I prefer to speak to the family, whether patient is very stable, very tricky, very much critical, very much troublesome, whatever it may be. So I involve primarily doing audio video counseling and appropriate documentation and all those things will make. So that after counseling, again, one quick rounds I'll do. So those rounds I am not going to disturb anyone. Means like I allow them to do procedure, okay, do their documentation or whatever their conversation with the other specialty people or radiology or lab. So all those things I'll allow them to do sufficient time. It's not like okay, each time I go and bother them kind of this one. So I'm not.
Okay.
So I'll just do like again to keep watch like everything has been started and moving forward kind of this one. Okay. So then like lunch, post lunch, usually we'll have some formal academic meetings kind of this one. So whether it may be a seminar or maybe some sort of the consultant driven lecture or maybe a case presentation or maybe a journal club kind of this one. So this is the post lunch 2:30 to 3:30 something we'll have. So like after that again like we'll go through the plan what we done and what happened since morning, and again evening plan will start making. Means like so this patient, what is the pending work, what need to be followed up, okay, with which super specialty consultant we need to have one more conversation regarding whatever the dynamics of the patient, so that I'll give a clear picture to them maybe somewhere around 4:35 o'clock kind of this one. So this is an overview how we are going to plan on the floor before reaching to the ICU. Both I'll club and will. So this is my routine on day in day out. So without any miss. So this is what we are going to do on the floor.
Seems like many of the people must be thinking of joining you at this stage, sir. Such an academic oriented round. Sir, just a question which many people have, that when you start the round, you go to the sickest patient per se, or you, when you on the on the drive to the hospital, you have jotted down that these are the patient or these are the things I need to address. So I'll go to this, or you start by 1 to 10 like that.
No, no. So obviously, see, triage system also needed like an emergency in the ICU also. So I don't go from A to Z kind of this one, because when I heard the story while on the way, so I make a plan, okay, whom I need to see first and whom I need to prioritize kind of this one. So sick patient, multiple support, rapidly deteriorating, or there is some diagnostic dilemma is there. Still, there is no clue. So, or maybe like patient with some sort of tricky family, or we need to disclose or discuss an important message with the family. So those kind of patients I'll address always. Like that will plan.
Okay, sir. That's very nice. S- Sorry. Sir, one question that we all know that ICUs are a team dynamics, means there are not only doctors, nurses, paramedics, other consultants of different specialities are there. So how did you bring them all on the same page, or how do you make sure that the team is there, whether on the rounds, nursing or other paramedics are also there, or how do you move the team as a whole in the ICU, not only the residents or the associate consultant which are there?
See, that is very important in managing critically ill patients because see, we do partial work. The partial work is going to be done from other allied health science people also. So nursing is the one who are going to final the chain to deliver the care to the patient. So they are very, very important. We make sure importance has been given to them and will involve them in the conversation and will give task to them also. Means like on day to day, maybe simple, okay, what is your understanding on ARDS? Okay, or maybe what is your understanding on vasopressors? So I suggest all of them. Suppose in your professional career, you are using a medication or an intervention for more than 3 times. Okay, you should know about that intervention or a medication by when you use that for the fourth time. Suppose if a nursing staff is writing meropenem or giving meropenem more than 3 doses, I expect I used to tell this literally. So you should know what is meropenem, okay, why we are giving, how to infuse, how to dilute, kind of this one. So it applies for any other specialty also. Will involve respiratory therapists. So I will ask them on the rounds, what do you feel this patient is ready to wean or not? So do you feel we need to go for tracheostomy for this patient, or like we can give an one attempt of extubation? So we'll put a question across a respiratory therapist also. So I'll make sure I'll ask, okay, how is the secretion? So do you feel like we need to change in terms of any way how we are mobilizing the secretion? So they need to do checklist analysis every day. Airway checklist they will do. So weaning checklist they will do. So if I tell them, okay, this is a patient planned for tracheostomy, they will do the checklist for tracheostomy, decannulation. So well-defined role pertaining to their specialty or allied health science, and I make sure they should actively involve in a healthy discussion at the bedside. It's not like, okay, we are the clinicians and we define and we dictate the terms and they need to follow. It's not like that. So we'll make sure that we'll take their input, because ultimately, as I told, like the partial work will be done from
Sir, we lost your voice.
you
Uh,
with all specialties involved, kind of this one.
Okay. Sir, I lost your voice. How about other than these allied branches, how do we make a coordination among other specialities? Do we have discussion on the round and then we communicate to them? Or how do we go about that, that we are all on the same page? This is very important, I think, in terms of
So
intensive.
there are two, three things I will follow, Ankur, at the bedside. See, as I told, like suppose there is an uncontrolled source. Assume there is a skin soft tissue infection who got admitted maybe in the late night, early morning, kind of this one. So is little bit rapidly deteriorating. So I got information while going to the hospital itself. Sometimes what I do is I'll not wait to reach the hospital. Then and there only I'll speak to the pertain. Maybe it's a general surgeon or maybe plastic surgeon. Okay, this is the patient who is in ICU. So on priority, you have to look this patient. That is one way of communication. Second, when I reach the floor. So sometimes what happens when I am around 8:45 to 9 o'clock on the floor inside the ICU. So many clinicians will walk to see a particular patient, maybe an intervention neurologist, or maybe a medical oncologist, or maybe a physician, or maybe a pulmonologist. So then, so if any point to be discussed, particularly, okay, to plan some sort of intervention or some sort of diagnostic modality, so then also I'll catch them then and there only, I'll directly speak to them. Okay, so this is what need to be done, kind of this one. So next level of communication, when we make a plan which is not so like urgent, kind of this one, so that follow up communication, so my team will do. But sometimes what happens if there is a difference in opinion, means like in my ICU, it is almost near to a closed ICU we run in terms of all decision making, in terms of the therapy, in terms of the diagnostic modalities. So that is my team and myself will take. But when it comes to say we want an upper GI bleed and it has to undergo endoscopy. Okay, so
Mm,
if the opposite consultant or a super specialist, if we tell no, we can wait, and if it is not rationalized, okay,
mm,
so then again I'll intervene. So then I'll discuss, okay, no, no, it is better to go for the intervention kind of this one. So then, you can tell if you have this kind of conversation, so 70 to 80% of the times, so I'm able to convince them. Maybe 15 to 20% of the time, we are not able to convince. So the problem is, like, whenever you feel there is a rationality to do something, so and if it is not happening through the communication through your team, like your junior consultant is speaking, so then you will tell, no, no, so we'll wait for dialysis, or we'll wait for like endoscopy later, or we'll re-explore later kind of this one. If you strongly believe there is a rationality, better you ring them, you speak to them, most of the
correct.
things
Mm,
started. Because see, one advantage what I have is uh, like whatever I achieved in my career, people respect that. If I tell, so that reciprocation, that reception is very, very good. So then they
very
think
true.
there is a rationality in that. So in that way, so I do agree in India. So many ICUs, they struggle, they fight. Okay, there is lots of difference in opinion. So from all aspects. Okay, so in terms of choosing an antibiotic, steroid, diuretics, okay, IVIG, albumin. So dialysis, when to do tracheostomy, someone will tell, will do, will wait. So lots of things will be there. But these are two, three ways we'll address. And sometimes what happens, like when we wish to communicate to the family, okay, by default, as I told, so ICU communication we do separately, means with a fixed time. So maybe
Mm,
around 11:30 we'll start counseling kind of this one with my team. But sometimes when we need to have a multidisciplinary counseling and all, so then I'll involve them. Means like, okay, you also come while counseling. So in terms of decision making or a tricky family or demanding family. So these are two, three ways how we are going to communicate. And I advise my junior colleagues also. First, you should have a strong knowledge what you are speaking. That is very, very important. Means if you are blabbering, okay, in terms of the evidence and the best practice around the world, so then obviously they will take them for granted. So they will not see. First, thoroughly you should read, understand the concept, then you open like in front of other specialty and all. So definitely the reciprocation is going to be very good in a rationalized way, in a polite way. So no need of arguing, but this is what I advise my junior colleagues also.
very helpful, sir. Very, very helpful. This is going to be very helpful to those who are listening. Now we just discussed regarding your day in the ICU, but just for the audience which is listening, we have a day of 12 hours in the ICU typically and 12 hours of night in the ICU. So many people feel that the maximum work is done in the daytime and the night is just for the observation. So do you feel it is the same way or the night plays a very important role in care of the patients? Those 12 hours in the night.
So definitely in terms of the care, it's a dynamic process. So you
Mhm.
can't tell, okay, we'll do an optimal care till say 4 o'clock in the evening, and after we go home, so then you are going to leave the patient kind of. So that is not going to have any fruitful impact in intensive care unit. So how we do is when we wind up, so as I told, we'll have a working plan for the night also. So then usually around 10:30 to 11 o'clock, I voluntarily call the ICU, okay, to understand what's happening kind of this one. So by that time, if any new patient got admitted from the ward, got deteriorated, or maybe from the emergency department, or on the floor got deteriorated, or new issues, I'm going to address, and we will give a working plan kind of this one. So after that, I give a very good scientific and rationalized liberty to my team. So I'm not going to bother. So in the night, they choose piperacin tazobactam instead of cefprozil sulbactam. I'm not bothered. Okay. So or maybe a patient, they given meropenem instead of like piperacin tazobactam kind of this one. So I'm not going to do like micromanagement like what happened in the night kind of this one. But they should not do a gross mistake. Okay, they given say like around 200 milliequivalent of injection potassium chloride in half an hour. That grasp. See, that is what I believe my team, and I respect their decision kind of this one. Okay. So they should not do a major mistake, or maybe a patient was supposed to get intubated 4 hours prior only, and they just postponed and patient had cardiac arrest. So this definitely will not, I will not accept. But that kind of care, like, okay, to save the patient in a rationalized way, so I'll believe the team. Okay, so then I'll support them in terms of their independent decision also. I'm not going to bother, okay, 11 o'clock one call, 1 o'clock one more call kind of this one, because most of our team members are they are trained in critical care medicine, and even fellows are post MD anesthesia, MD internal medicine and all. They know the rationality to some extent. So unless otherwise, okay, it is very tricky. Someone we need to initiate maybe in the night itself, say ECMO. Okay. So then they will give a call. So they need to initiate ECMO in the night, kind of this one. So or they wish to initiate CRRT, okay, with a rationality. So they will take their own call and they will give an FRO and they will tell, okay, this is the patient who needs CRRT, kind of this one. So that's why we need to balance, because see, it is not a 1 day program. So it's not okay. This day you finish and whole night you are going to awake and you take the call throughout night. It's not only, you need to do this job throughout your career, professional career. So you need a plan and you need a robust system and trained people around you, and you need to believe them and you need to respect their couple of decisions also.
Very true, sir. And nighttime is, I think, one of the 12 hours where things make a difference when we see the patient in the morning.
Yeah.
So this was about the technical aspects, sir. A little bit about the emotional aspect of the ICU also. Going through such a robust training and all the hectic schedule, were there some moments which you felt, some story where you felt that this is it, it was all the worth, I chosen this field, some story which was very heart touching to you?
So basically, like we have this almost every alternative day. So one good story, good emotional story where we feel proud, we
Mm.
feel motivated. So if you wish, I can quote one or two examples here. So one young patient was studying, like he finished his 10th standard, he just joined PUC 11th standard. So basically, in one of the peripheral hospital, like he got admitted. So with some sort of the skin manifestations and all, fever, like typical febrile rashes kind of this one. So then they treated there. So in the next 24 to 48 hours, like multi-organ dysfunction, he received one session of dialysis. So he got shifted with my reference to my hospital. So very poor, non-affordable family. Okay, no insurance coverage, kind of this one. Multiple things, whatever you mentioned, thrombocytopenia, so renal dysfunction, ARDS, once dialyzed already, skin manifestations, like encephalopathy, came on ventilator. So then, so differentials were complicated tropical illness ruled out. So maybe antiphospholipid antibody syndrome, a mixed connective tissue disorder. Okay, so lots of workout has been done, and vaguely some connective tissue like ANA profile came as weakly positive, but we are not able to do a major intervention for that because he was not strongly positive for that investigation. So then like we started him on like after some sort of conversation and rationality and all, we pulsed him with methylprednisolone for 3 days. So fourth day onwards, his creat settled, platelet improved. Okay, so we weaned him almost near into 8 to 10 days, kind of this one, without any tracheostomy. He came out. Okay, so he woken up without any encephalopathy. He was having some sort of critical illness, myopathy, and all. So then physio rehab and all those things happened. So the joy we can see in a innocent village background people, patients, mother and father, it is priceless. Okay, so this is one story. And again, recently 2 3 days back, we have one more patient, was a thalassemia major. Okay, multiple transfusion, so came with febrile illness, dengue positive, Low platelet, started bleeding from everywhere. His liver enzymes went up to 7,800, almost
Oh,
8,000.
7,000. Okay.
Ammonia was more than 150. So acute liver failure, like severe dengue hemorrhagic fever with the background of thalassemia, post splenectomy. So he's a
Oh,
software engineer. So he's working as a software engineer in one of the IT company in Bangalore. They are from Orissa, basically. Parents, educated family, okay. Lots of emotional things. We thought we are going to lose him. So intubated, 2 sessions of proning, so renal dysfunction, liver dysfunction, encephalopathy, multiple attempts of failed weaning, tracheostomy, so weaned and he gone home. So these are some of the priceless lives we save. So this is what it give a kick and motivation on day in day out in practice in intensive care unit. So lots of stories like this.
the flip side is also there, sir. At times you put lot and effort because we as intensivists know that we put our team put almost everything they could do to save the patient to bring the change. But at times they must be having that sometimes the patient or the family members are not understanding, even the consultants at time other specialties not understanding. So how do you handle that? How do you handle this such difficult conversations, sir? How do you handle this thing?
So in our unit, no, Ankur, see, it is situated in one of the main IT hub. So where my hospital is there, so lots of techies, lots of immigrants from across the country, from North India to South India. So many people stays there. When we receive any patient, okay, say whether it is some sort of COPD exacerbation or maybe some sort of acute febrile illness or like cardiogenic shock, whatever the etiology or diagnosis kind of this one, first to make them understand the severity and the belief in the doctors and the institute, it's a real challenge because what is going
Hmm.
to happen is like they are like most of them many a times they are preoccupied. So when they enter into ICU, so they think, okay, unnecessary things will happen. So what is the capability of the team, doctor? So all those things will start in the initial hours. So many a times what is going to happen, like night, they will ask, no, no, we want us like summary, second opinion, this, that, and all. So when I reach ICU and when I speak to them, like on the floor during the counseling hours, first time when I meet, will make sure the transparency is maintained and proper thorough prognostication and the line of management, and I'll give sufficient time to them. So then, like they go to the market, okay, so they do their research. So in terms of their Googling and asking here and there, they will come back. They will come back and they will express, sir, we heard about you. Okay, so we don't want to go anywhere.
Okay.
So it is totally entirely it's going to change the picture itself. Means I don't know. That is like favoring point for me. But till now, touchwood, none of even patient for unfortunately deteriorated. Whatever with the best efforts you put to save him, even a young patient, if he died also, that goodwill they know that we have done a things rationalized way, in a transparent way. Okay, and many a times see lots of request will come, sir. My fans, the typical way. My family
Typical.
doctor is there in US, UK. Okay, or maybe in the family there is one Ayurvedic doctor. Okay, so I with a calm mind I'll speak to them. So I'll put a loudspeaker in front of the relatives and I'll make sure. See, that is how we build the trust in them. So then lots of issues are going to get sorted out. So in terms of their agitation, their doubt, their arguments, everything will get calmed down. So initial 1 or 2 counseling, you need to give a sufficient time. After that, we are very straightforward. Means what is the plan? What is the condition of that patient during that time? I'm not going to again sit with them and will listen to the entire story kind of this one. If I sit for one counseling or maximum 2 counseling, okay, I'll make sure. So then the remaining things are going to be very smooth. Even if I am not there on the floor also, there is no fighting, no argument with my team members also. It works in a smooth way kind of this one. But unfortunately, extreme like relatives will get out of emotional outbursts if any untowards outcome happen. But that also will manage. Will tell because they will get convinced by that time. Like we put all our efforts kind of this one in a rationalized way. So that is how we need to win their confidence.
So being transparent and the initial one or two detailed counselings, I think these are the key which
Yeah.
gives you a smooth build up. So we have seen your critical care journeys, ups and downs, emotional aspects of the ICU. So if I ask you, somebody who wants to be in intensive, what qualities the person should have? Just few of them. What means what temperament, enthusiasm, or endurance, whatever what you feel should have one who wants to be an intensivist.
One, you keep your communication skills very good,
Very good, very nice.
and that is very, very important. And you should be a very good team player. So whether whatever the hierarchy you are working, you are leading a team, or in the sub hierarchy, or you are just at the entry level, you should be a very good team player. Learn about some legalities, documentation, because we work in a very susceptible, like professional environment, particularly when it comes to critical care. You are dealing simultaneously with the patient family, and if you are working in a mix, open intensive care unit, majorly you are dealing with the other specialty like consultants kind of this one. You should document, and should have some sort of legal knowledge what you are doing kind of this one. So with this, you should have a very good empathy. Okay, so calmness. You should not lose your temper, should have a patience in waiting for the patient dynamicity and the outcome, also while conversing. See, many a times, like even relatives also, they will tell, sir, we got information, they told like this is not necessary, you are doing this one. You be very calm. Okay, don't start behaving with anger or lose your temperament. So patience is also very, very important. Then majorly you need to update, upgrade yourself with an open minded approach. You should not be very rigid in your thought process. So you need to revise. Okay, you need to freshen up your thought process as the evidence evolve. Okay, as the world move towards better outcome oriented practice, that you should have always eager to learn. That is very, very important in critical care medicine.
So, sir, just regarding your last point, eager to learn. So, intensive care, we feel that it is something which is very fast. Research is going on, newer guidelines coming up, new journals coming up. How one should keep updated? How do you remain updated on all the latest info at this stage?
Best way to update yourself is like in a standard journal, go for the review articles. Okay, so it's not possible to read each and every like some sort of the randomized control trial, maybe small to big, observational to retrospective to cohort study and all. So better way is on any particular topic you read the time relevant review articles, because review articles are the one which starts with pathophysiology to the rationality and management, and they criticize the current practice. So, and they give some sort of fair conclusion kind of this one. So review articles are very, very important, meta-analysis are very, very important. So if you just put in the Google, you will get lots of garbage in terms of material available in terms of any topic.
Yeah.
uh, like you need to screen in terms of the weightage, in terms of the recentness, okay, and in terms of the credibility of the journal where it got published, kind of this one. So those things you need to concentrate. See, many a times reading textbook may not be sufficient, particularly in critical care medicine. So I always advise read review articles. I just want to quote here. See, even almost, as I told, almost a decade back, 12 years back, when I started my critical care medicine journey as a resident, see, I used to download a review article. I was having a printer. So you take a printout, then you start accumulating those review articles. Okay. Liver folder, ARDS folder. So then sepsis folder. So like that, when I finished my DM critical care medicine, so I was having this much book of 24 books, review book.
Review article 20. Oh,
So this
24.
much, this much books. What I made, like finally my wife given an index to each article. Okay, in liver. So this is kind of this one. We put a page number, and I made a spiral bind. Okay, when I left Mumbai, like after my finishing my bond period and all, so many people from my Alma, that is Tata Memorial Hospital, and different medical colleges, different corporate hospitals in Mumbai, they took Xerox of those.
All those notes.
See, I really tell, I never read thoroughly any of the textbook kind of this one in critical care medicine. So take a review article and put it in that folder. 24 books. Okay, 24 books of this much size kind of this one I was having.
Huge.
Yeah. And by the time, like for exam of whatever you mentioned, so then like thoroughly I used to revise like this. Okay, you just turn the page. So I know where it is, what it is kind of this one.
Visual memory sort of.
Each page I was aware, okay, so in this page what I need to have some sort of take home message, because that is very important. I'll suggest, see, you can't open the Google every time kind of this one, okay. You should have a thorough take home message on each molecule, or on each concept kind of this one. If anyone asked, for example, tigecycline, okay, you should tell glycycline, tetracycline. It is not going to cover Proteus, Pseudomonas, Providentia, Margonella. It is not an option for bacteremia, urosepsis. Okay, it is highly lipid soluble. No need to do any adjustment for the renal dysfunction. Okay, only concern is there for liver dysfunction. In ventilator associated pneumonia, it showed increased mortality in 2012 publication, but the problem was there was insufficient dosage. Current dosage recommendation for sick patient is 200 milligram stat followed by 100 milligram BD. So it is good agent for biliary sepsis, intra-abdominal infection, skin soft tissue infection. Okay, so don't preferably give it as a monotherapy. Okay, so give it as a combination. See, at least if you remember this much on each molecule, okay, so that should be your take home message for the life kind of. You are not able to revise each day, tigecycline again, you Google it and again you do this. It is the same for phosphomycin, it's same for minocycline, okay. It is same for driving pressure, okay. It is same for mechanical power, okay. So you should have your own take home message. That is how you can excel in critical care medicine.
So you are an encyclopedia in yourself.
No, because see, it is not like uh, see, I'm involved with everyday discussion. That also makes your memory track very, very crystal clear, kind of this one. But that is what I suggest for all like young beginners. At least may not be on huge topics and all, but at least you make your prioritized topic as a take home message. Take home message, that is very, very important.
Very nice, sir. Sir, just a continuation of this. In the last 10-15 years, what we have seen is, although remaining update is important, and also the technology has also evolved very much. In fact, in the post-COVID also, we have seen some changes, many changes. So how did you feel that the intensive care treatment or management has changed or evolved over a period of 10 to 15 years, from the bedside equipment to technology driven to post-COVID? How do you feel this transited, and what still holds the key in managing such patients?
See, like it evolved in like many areas. Maybe if you go back 2 decades back, people used to think if patient got shifted to ICU, so then gone.
Mm.
Okay. So he's going to die. So next the concept was, okay, ICU is okay if patient is being put on ventilator, so he's going to die. So that was the concept. Okay, so maybe in the 1.5, 2 decades back, kind of this one. So lots of improvements happened in terms of saving life. Maybe it's diagnostic modalities, from waiting for culture sensitivity for like 3 days and all. We have rapid diagnostics, from like gauging fluid management. I remember still. So in our anesthesia residency and all, measuring CVP was with a scale. You see that you cut one
Uh-huh.
IV fluid, like
Intricate IV line.
IV line, and see how it is going to rise, and you measure with the scale. This is 20, 15 years back. So when I was in second year of my MD anesthesia, kind of this one. So lots of changes happened in terms of hemodynamic monitoring, like invasive, non-invasive, minimally invasive and all. See now, healthcare innovations and startups, there is a collaboration between the healthcare providers, that is the clinicians, and that of the technical persons. See, 2 days back, so people approached me. So you are aware, like we use it something called bioimpedance, bioreactance, and all for cardiac output monitoring. Okay, so bioreactance we have that Starlink's principle, cheetah monitor, and all. So bioimpedance, which never clicked in a very good way because of the error prone kind of this one. See, the people, one of the person who met me was a PhD holder, and one was a ex-employee of a GE Healthcare. So he was a technical person. So they developed very portable. See, what we assume is our monitor is this much, and we need for bioimpedance also we need some sort of like an electrodes which looks like an ECG, and we make a box around the heart and which measure the impedance of the thoracic cavity. What they developed, it is a small like a pacemaker kind of machine. You can keep or attach here. Okay, two electrodes like will be there across the carotid kind of this one. So then they are planning to introduce this technology for getting the values like stroke volume, cardiac output, okay, stroke volume index, and extracellular fluid, like how we measure thoracic lung water or maybe extravascular lung water kind of this one. And it also gives some sort of idea about the left ventricular end diastolic pressure. So basically, the science is becoming more and more compact. Okay, they are planning to introduce this kind of monitor for management and monitoring of heart failure to predict the decompensation of heart failure. See, these kind of technologies are evolving. Okay, so in future, lots of things we can expect in each area. As I told, in diagnostic modalities, in monitoring, in terms of interventions, therapeutic drug monitoring is going to come up like anything. Okay, so TDM we were using only for vancomycin trough and peak level. Okay, then we use it for azoles, amikacin. Now it's going to come for all beta lactam group of agents. So rapid diagnostics incorporating like artificial intelligence and all those things in a protocolized way, in predictive models are going to come, like biomarkers in a sophisticated way. So these are all evolved in the last 1.5 to 2 decades, and it's going to happen in the next coming years also.
Well, very nice, sir. Means from measuring to IV line into coming to here, very fast journey in those 2 days. But still, you feel that the bedside clinical examination plays a very important role in the ICU.
Mhm. Because see, so without your integration of all these things, okay, so you don't have a capacity to conclude what need to be done at the bedside kind of this one. Okay, you have some sort of passionating biochemical reports, hemodynamic monitoring, and their risk profile, okay, dynamicity of their disease, and what therapy, what intervention you are doing. So with that, your clinical judgment is very, very important. Even though you have lots of incorporation, but finally it comes like you are the one who is going to decide what need to be done in the next hour or in the next minute kind of this one. But saying that, if you tell no, I don't adapt the evolving technology, I only stick on to clinical, I'm a clinical person, that's going to be not going to improve overall clinical outcome in coming days kind of this one. Okay, because we need to evolve, we need to fine tune. So that is true for what's happening in the world, that is artificial intelligence and all those things.
Okay, sir. So, very importantly, listening to all the emotional aspect, technologically driven clinical examination, all such families. At times comes a point that after doing 10 year, 12 year, 15 years of work in intensive care, many people feel burnout or it become challenging to maintain a work-life balance. And maybe after 10, 15 years, they jump to, or they want to transit from critical care to administration to research or something like that. So, any tips or any views on this, sir, which can help our audience?
Lots of parallel, like some sort of options you should have always. One is clinical work. You need to take it with you throughout your professional journey. So other than that, okay, like you explore what other taste you have, maybe in research, or maybe in speaking, or maybe as an advisor, or you want to do some sort of maybe healthcare related content creation. Okay, or you want to become an entrepreneur. So maybe you made some corpus and you want to invest in a non-healthcare, or maybe healthcare in and around. So may not be a hardcore and hospital. Okay, you want to like invest maybe in say home care facility, okay, or tele ICU facility. So you want to become a partner with some sort of like rapidly evolving home care provider. There are many companies, okay, in India, because everyone is expected by 2030. So most of our population is going to be geriatric.
Yeah.
They need some sort of like out of the hospital, out of the ICU care, palliative care, home care kind of this one. So you should have
Sir, we lost your voice.
you can get the opportunity, like, or maybe you are one of the like founder with one of the startup company kind of this one, okay. Research, like investment, or you might be having a huge invest means like some sort of interest in maybe a share market, okay, mutual fund, whatever. So definitely like you should have like open-minded ideas. And also I'll tell here, see, when I was doing my DM in 2012 and all, literally I was not aware there is something called share market kind of this one. No idea. 2012, I am telling. Okay, when I
Very
was
recent. Yeah.
so when I was in my second year of DM, okay, no idea what's going to happen kind of this one. Okay, see, when we were doing our post graduation or maybe like super specialty kind of this one, we are almost in 30s of age, means 29, 30, 31 kind of this one. Okay, it is very late if you don't understand what's happening in like personal financing or maybe investment and all those things. So basically you should thoroughly have that knowledge. Okay, nowadays like you will get lots of knowledge, lots of media, lots of like ways, digitalization options are there, but you explore with your interest whatever you want to do, but keep one such option always open with your like professional career.
Very nice, sir. And this also helps to maintain a work-life balance also, I think. If a good knowledge, good team building, have a second or alternate source of passion like that, it makes you feel joyful and be purposeful. And continuation of this, now we'll come to, sir, your this extra curricular activities sort of thing, but I won't say extracurricular. This is your main thing nowadays we see is harishcriticalcareclasses.com. When this idea came in your mind that I need to make a platform for students to teach critical care in a very simplified, even though it's a very thorough lectures, but they are simplified in such a manner. How did this idea born in your mind? Tell us a little bit in detail about harishcriticalclasses.com.
Basically, Ankur, so it started almost during the COVID first wave in and around. Okay, so idea was uh, like everything collapsed. You know that like all collapsed in terms of our routine work, and overnight we closed PP, this, that, and all. So academic gone totally. Okay, so then my thought process idea was, okay, we'll create something like some sort of teaching method for Bangalore. So like that, or maybe my institute kind of this one. So then with that, like I thought we'll create one platform to have for digital learning and teaching kind of this one. So then like when I planned for this one, then I understood, okay, you need a website for it. Okay, so then you need to have some sort of like creation of the content. So then I look back on my own already what material, what stuff I was having, because uh, in my DM itself, I was a national faculty. So
Mm.
when I was doing DM, so in hemodynamic monitoring and like couple of like drug resistant organism, nutrition, so many field I given lectures and all. So then I was having a idea, okay, what thoroughly prepared in terms of the material kind of this one. So then um, created a platform harishcriticalcareclasses.com with almost 70, 65 to 70 lectures in the first batch. So then I understood, so there is a need to like widen it so that they should not feel they miss anything kind of this one. Okay,
Okay.
so then like each batch I started adding at least around 30, 35, 40 lectures kind of this one.
Okay.
uh, so in the initial days I used to go live. So people used to attend, we used to get record. So I used to converse directly. So there is no way if anyone asked a doubt. So then I can't tell, I will tell tomorrow, I'll read and come kind, because I am going live. So it made me to thoroughly prepare for each topic kind of this one. So there is no
Yeah.
hope, okay, you just do some this one and I'll just deliver the lecture, because I'm live, totally live kind of this one. Okay. So content created and it started accumulating kind of this one. So idea was not just to make any person to clear their theory or a practical exam. So that was not at all an idea. See, from the day one itself, our quote was, it should help for a physician, pulmonologist, okay, any clinician who want to change his practice
Mm.
in terms of managing critically ill patient. That was the tag. So all these EDIC preparation, EDIC Part 2 preparation, DMDRNB or DMDRNB, INICET entrance, these are all the byproducts, okay? But main agenda was to make a change in terms of like impact creation, in terms of like changing the practice of critical care medicine in India and outside India kind of this one, okay? So then it started like cumulated kind of this one. So it is now currently it become whatever we planned.
No, 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 no. It has created a lot of impact, sir. We heard your story regarding the patients. Could you have one or two small little scenarios or stories regarding how this harishcriticalcareclasses.com has made an impact? Do you remember one or two few incidences?
Basically, see, uh, like when we moved out of the COVID, so
Mm.
then like all these movements started. Okay, we started going here and there. So it's like a new like world kind of this one. Before that, like sit in front of the camera and webinar, seminar and all. In 1 month, I remember, in 1 month, okay, I've given 27 webinars in one of the
Almost daily.
almost this is I am telling other than our masterclass kind of this one.
Okay, okay.
So 27 masterclass, if you count, it's going to cross more than 50 kind of this.
Uh-huh.
So the impact Harish critical care classes and master classes in critical care medicine created, no people. One of the clinician who is a physician who was working in Qatar. Okay, so he done his MD medicine from India.
Uh,
Then after COVID, like weaned off, so he came back to India, because by that time, like till that
mm,
time, there was no option to like international transfer and all.
mm.
Then he like when he came back to India to visit his family, he's from Kerala. So then he called, sir, I'm coming to my hometown. I want to meet you, sir. Then I told, okay, you come. I thought, okay, how he
Mm.
is in Kerala, how he's going to come to meet me in
Uh,
Bangalore. You know. Then one evening he called, sir, tomorrow morning I'm reaching your hospital. I want to meet. So then he met me. So then first thing, so I met him in corridor. He touched my feet like this. So he's a physician, a clinician kind of this one. He told, sir, I attended master classes almost by the time third or fourth batch finished. Sir, we saved many lives in Qatar. Okay. In COVID ARDS, the troubleshoot, the doubts you are going to clear, and like watching your videos and all. So we saved many pregnant COVID patients.
wow.
Uh,
Uh,
our Qatar government recognized our hospital works, and we got some very good recognition, honored kind of this one. You are my critical care guru for the entire life kind of this one. Okay. Really like shocked kind of this one. Okay. Then like many my students also, they used to call, sir, I'm in Bangalore, I just want to meet you. So then started wherever I go to like deliver any lecture to any conference and all, sir, we are coming to conference just to meet you, sir.
just to meet you,
Yeah.
just to see
Yeah.
you in
We
person.
want to take a photo, sir. This, sir. They started uploading in their social media and all. And more than that, see, these are all like working in like good tier three cities in corporate hospitals and all. What's like given me very like satisfactory in terms of my work was like those who are practicing in district hospital, physicians,
Mm.
alok hospitals. Okay, even couple of people, they were my MBBS seniors. They done their MD medicine and they are practicing. They attended our classes, kind of this one. Okay.
Great.
So then they told Harish, we are managing the patients on the floor. We stopped referring them out, and not losing them, particularly OP poisoning, okay, acute liver failure, COPD exacerbation. We have a confidence in managing them. We are saving the life, kind of this one, in district hospital and in taluka. See, in many platforms we do something called critical care outreach program and all. Okay, what major thing can happen more than this as an outreach program, kind of this one? So many like nations, India Nepal border is managing a small ICU there. Okay, Bihar, like I got see, my follower, he called me one day. So then he told, sir, I want your address,
Acha.
postal
Okay.
address. Then I thought, okay, I thought the address, kind of this one. So then, so he had one link in Bangalore. So one of his friend or some kind of this one, he called me, sir. You have some parcel from Bihar, like from XYZ doctor. So I have that parcel. I want to deliver to your home, kind of this one. Then I thought, okay. So he sent a Raymond suit for me from Bihar.
Oh,
So this happened like twice from Bangladesh. Like
okay.
so see, many stories, like it is very, very heart touching, kind of this one. What I really enjoyed is like this is not just clearing their theory MCQs or entrance exit exam, kind of this one. It created an practice changing impact. And many of the anesthesia head of the departments, okay, many of the medical college HODs, they attended our classes, kind of this one. They attended second batch, third batch, fourth batch. They're keeping themselves updated, kind of this one. So uh, these are some of very heartwarming stories I have.
There may be many, I think.
And more than that, Ankur, see, it is uh, like just delivering a lecture and close it there. It's not like that. We have something called voice of critical care medicine.
Yeah, yeah, we know.
Usually, like I'll get at least say around 6 to 8 queries. In that, some 2 3 queries are real case related. Means they are managing the patient on the floor. 99% I'll make sure by the end of the day. So I'll give them an answer in a take home message. What need to be done, kind of this
Yeah.
one. So then it will become a depository in the voice of critical care medicine that is a continuation. So in terms of any help they need, it is beyond the master classes in critical care medicine. So in a multiple way, in whatever the way, I can give service back to critical care community. So I'm doing that. See, that is what is satisfactory basically. So and it gone beyond. See, when I was supposed to start almost now 5 years, 4 years, 11 months over with rich critical care classes, I asked my own residents. So I'm planning to start something like this kind of this one. Then they told, sir, there is no doubt you are a good like teacher concept and all. But if you create something and need to pay for it, we have a doubt people will because there are
Yeah,
lots of YouTube, lots of webinars, lots of seminars, lots of conferences are happening. Each weekend something will be there. We don't know, sir, whether people will pay and will attend, kind of this one. It gone beyond that. It gone beyond that.
I can understand.
That is
I can, sir, this is such an amazing resource. I can tell you, many of the viewers who are listening, they know how useful are. So, sir, now 2 3 questions regarding the future intensivist or young generation or members, those who are listening. A few words of advice for them. Now, first of all, from you, we want to know what are the courses are available in terms of critical care per se in India when we are thinking when one is thinking of doing critical care or choosing critical care as a career.
See,
India.
there are courses in relation to duration. We have like university run postdoctoral fellowship courses under PDCC.
Hmm.
We have Indian Society of Critical Care Medicine IDCCM, that is 1 year, and after that you can enroll again for IFCCM. So total 2 years of training. So that is one way. And like from the national board, we have DRNB critical care medicine and DM critical care medicine. So FNB, it is collapsed once we got DRNB critical care medicine. So basically university run program. So Indian Society of Critical Care Medicine run program and DRNB DM critical care medicine. Okay. So now like with the DRNB or DM critical care medicine as a not as a standalone critical care, they clubbed onco critical care. Okay, critical care with transplant anesthesia. So certain institute they are tagging it as neuro anesthesia and critical care. So those kind of courses are also available. Like basically, uh, the candidate can choose uh, which like course you want to opt depending upon is place where you want to settle. So what kind of lucrative options you want to have, whether it's in a medical college, corporate hospital, what kind of remuneration you want to earn, okay, what kind of recognition you want to get in his professional career accordingly. So these are some of the options we have in India.
And sir, some fellowship courses like EDIC and all others are there. They
So this
can.
is in India, I told. So when it comes to add-on, like you have European Diploma in Intensive Care Medicine and European Diploma in Anesthesia and Intensive ADIAC is also there. Okay. So my always strong suggestion is with your MD or DNB, first you have one basic qualification in critical care medicine.
Mm,
Then you think on doing EDIC because EDIC is not a full-time program. So
mm,
it is your assessment of your MCQ skill, and EDIC part two is clinical skills and all. But always I suggest you should have some basic degree, whether whatever it is, like depending upon your like choice.
mm.
One thing. So other than that, like across the globe, Australia you have FJ, FICM kind of this one. Okay, in UK you have FICCM. So
Got it.
options are there.
Got it, sir. So if I need to sum up, what one piece of advice you will give to the candidates who are pursuing their career in critical care? What one thing you would like to tell them?
See, whatever you do, whether it is an IDCCM, IFCCM, DRNB, see, I touched everything. Like, okay,
Yeah.
nothing left.
Mm.
I touched 15 years back.
Mm.
FNB to like DNB and IDCCM, DM, everything.
Anything we say you are there.
uh, Wherever you work, you burn like anything during your residency. Okay, burn like anything. Don't like have excuses. Okay, that is very very important because whether it is in terms of your like learning the skills, rationalizing the things, presentation, publication, very very important. So once you are out of the institute, okay, very difficult in your busy schedule to make some sort of research activity or publication and all. So on the floor during 3 years or 2 years or 1 year, you burn like anything. So that is very, very important. Okay. Don't choose any some sort of alternative pathways and all. Like you should always keep learning. Okay. Then hand in hand, see now uh, in my days, okay, EDIC was planned post DM kind of this one. Okay. Post
Okay.
means like our thought process, okay, maybe we'll finish first DM or DRNB, then we'll look for like edit kind of. Now my students in the second year of their DM or DRNB, they are ready with edit part one and part two both, like that. Okay,
So much has
basically,
changed. So
yeah,
much has changed.
yeah. So
So this was the advice to the candidates. But I we listened to your journey, very ups and downs and all. Very means how do you sail through? You make it so purposeful that everybody got inspired. But if you can go back in time and change or give one piece of advice to yourself, what would have you have done differently if you feel?
maybe if I was having an option, if you go to pre-MD anesthesia era, I still feel okay. I could have put some more effort to enroll into maybe like MD internal medicine kind of this one. Okay, because see, in India, it's a mix when it comes to practicing critical care medicine. Either you are from an internal medicine background or you are from an anesthesia background. Now you have emergency medicine and couple of people from the pulmonology background also. So I don't know. So this is one thing I wish I could have done. Okay, maybe internal medicine. but it's not like sometimes I feel okay, many people will ask me, sir, we feel you are from like we thought you are from general medicine background kind of this one, because
Acha, okay.
it is the way I put my thought process. See, basically, general medicine is differential diagnosis, antibiotic. Okay, those are all little bit above, but I am mastered in that. So, but this is what I felt sometimes. Okay, like that was the only thing. Otherwise, I'm very happy in the pathway which I chosen, where I am today. Okay, I'm very happy. No repent on that.
So we are also very happy, sir, to have you on the ICU channel on ESBICM. So before closing, sir, some of your thoughts regarding to your viewers regarding the ICU channel by ESBICM, if you had come across or if you had any thoughts or views regarding this.
Um, Ankur, when I visited your channel, like before visiting, my thought process was okay. You are also one among the people who create like on YouTube some lectures, this, that, and all. But when I gone through the like material, the stuff what you created, it is fantastic, no doubt on that. So that is also needed. It's not like okay, just a didactic lecture kind of this one. So you are taking in a comprehensive way what an opposite person want actually. So that is mimicked in terms of your subscriptions, your like conversation in terms of feedback. So I gone through many of the feedback and all. You are doing fantastic work. So content is very good. Keep it up.
Thank you, sir. Thank you, sir. And we are from the whole ICU channel and ESBICM and all the members, those who are watching this telecast or recording, who will watch this recording. Many thanks, sir, for coming and sparing time this us. And I tell you, sir was having only 30-40 minutes with them, but he has spared more than 90, almost 1.5 hours for us. Sir, I can assure you, your words are going to help a lot of people in the field of critical care and choosing their career. And even those who are listening, they can modify their round taking skills, communication with the family, and lots of learnings are there in this words of wisdom of once 90 minutes pure academic life changing podcast or interview, whatever I say. Many thanks for coming, sir. Many
Thank
thanks. Thank you.
All the best, Ankur.
Thank you, sir. Thank you.
Bye bye.